Welcome everybody, and I'm pleased to say that we've got Siobhan Callanan here today, sitting in for Jonathan Wade from Medway Maritime Hospital. Welcome Siobhan, and thank you for coming to your first meeting. So I'll just reiterate the apologies for absence. Councillor Peake, Councillor Jones, Councillor Curry, Caroline Rickard from the local, the LMC, Martin Riley, but Chris Wright is here, hopefully. Is that? Thank you, Chris. Yep. Siobhan's here, and Mark, you're here for the ICB, so that's really helpful. Thank you. Yep. And for those invited, we've got apologies from Adrian Richardson, but Victoria is here, so that's really helpful. Thank you very much for coming. Okay. So I'm going to look at the record of the meeting for our last, just find the page. And just go through that quickly. We looked at active travel and thought about the way that affects the whole population, including some of the traffic management options that we were taking. We looked at safeguarding through the Children's Partnership. We had the suicide and self-harm prevention strategy. I'm pleased to say that went through Cabinet on Tuesday and has been very welcomed by everybody, and the comments from here were helpful. And then we had an update on GP services and neighbourhood health. And since then, thank you to those people on the board who attended the training. We have got, because we have to do a neighbourhood health plan from the Health and Wellbeing Board, where we'll have another training session, but we've postponed the one that Stephanie went round to you all about twice, asking for dates, because there's an important piece of work going on about local government reform that we need officers to be there. And actually, since we last had our training, the deadline for producing the plan has moved to May. So we've got more time than we originally thought we had. And actually, we're still waiting for guidance. So hopefully, we will get the guidance before the next training session. But in the meantime, you know, lots going on. We had the ICB consultation about neighbourhood health. That was very well attended. And there are lots of things going on. We mentioned it yesterday at Hospital Governors. Siobhan, we had a chat about how the relationship between acute and community is happening. So I hope by the time we get to the training session, we'll be tooled up to get the plan in place with perhaps more information than we would otherwise have had if we'd taken it earlier. Okay, thank you. And then we were lucky to look at the Waking Up to Sleep annual report from David Whiting. That's attracted a lot of attention, actually, from across the public health community and went through council with a high level of interest too. Any comments, please, on any of the record of the last meeting? Okay, thank you very much. So everyone's happy to accept that as a record? Yeah. Don't see any dissent, so we will. Are there any urgent matters or any disclosable pecuniary interest or other significant interest, please? No? Okay, that's great. So we'll move to the first item, Andrew, that's for you, the Kent and Medway Safeguarding Adults Board annual report, an important document in the cycle of the local government partnership. Okay.
Thank you, Chair. And thank you for the invite to actually present this. From a safeguarding adult perspective, this is a really important document because it gives everyone who's part of the Safeguarding Adult Board the opportunity to see how we are all doing against our strategic priorities. So the report is carefully considered and written by Vicky next to me in relation to highlighting those points. And I, rather than go through and pick out detail, it's circulated in advance, given you all the opportunity to read it in advance. I'll just highlight a couple of things, not from the report, but just for your interest. The The first thing is that, and this was a request from Medway, that we separate into the report Medway specific items. So in Appendix 2, you will find Medway items. I've been in this post 5 years. It's only taken me 5 years to achieve that. So I'm quite impressed with myself to actually getting that one over the line. The other thing is, and Vicky has done this, and I think it's really important. We've had a real focus in relation to homelessness and rough sleeping, and we've put a specific agenda item within the report focused upon rough sleeping. And Bex Wilcox, who from Medway here, is our lead for the Safeguarding Adult Board on that item. So brings a lot of the good work you've done here in Medway to the board, so we can share it across the whole of Kent and Medway, because we're Kent and Medway board, but specifically takes that to the districts as well. So, I mean, I think that's all I want to really say in relation to it. And I invite any questions people might have from it for Vicky to answer.
Andrew, please.
Thank you, Chair. It only seems like a minute ago that you were here before, Andrew. These things seem to come round rapidly, don't they? I've just got 3 questions, hopefully. Okay. I note in the report the increase in the safeguarding team has increased by 100%, page 21. I'm just wondering what impact that's had in terms of the dealing with the backlog of section 42 inquiries, and are we seeing an improvement in that area? Also on page 21, the MIST team have been managing cuckooing and home invasion concerns. I'm just wondering how we're measuring the success in those cases, and are we actually seeing a reduction of referrals or intelligence that there is more cuckooing, or hopefully less cuckooing going on? And finally, just on page 74, the data indicates that neglect and acts of omissions is the most prevalent type of abuse in Medway, which is significantly higher than the national average. Just any thoughts on what specific interventions have taken place or are to be taken place to target at-home care providers to address this? Other than that, just to say it was a good read, and thank you very much for bringing the report here today.
Thank you. Back to you and Vicky.
I'll start the ball rolling, but there will clearly be aspects of this that Jackie can answer far better than me. So all the points you raise are very valid, and the board are actually very focused upon. I'm just going to go to the thematic, and I'll let Jackie answer the first 2 points about the MIST team, and also the first part you mentioned about the Section 42 inquiries. We are about to publish a thematic review on self-neglect because, like you, we all can see the rising number of neglect issues that we see through our SARS, through our SAF process, and actually reported incidents. So it is an area of concern for everyone who's part of the board. I'm hoping the thematic is going to give us some insight as to how the system, because we do have a self-neglect policy that exists across Kent and Medway, which doesn't seem to be making the inroads we hoped it might. So this thematic review will look at the system and give us some views against why is this not working quite in the way it should. Medway are ahead of the game because they've got their MIST team and they've got that focus around some of these areas. And can I just say, I'm really impressed with the approach Medway's taken to some of these big issues that they actually see through their Section 42s and the self-neglect. But I'll let Jackie give a bit more detail.
Thank you. So if I talk about the data first, so we've seen a 167.5% increase in safeguarding concerns in 5 years. So that's why we've increased the team by the 100%. It goes up year on year. And while not all of those go on to convert to a Section 42, and I have got the data, but I've not got it in front of me, so I'll put something around afterwards. Although they don't all go on to that, actually sometimes the amount of work that it takes looking at the concern and determining whether it does meet that eligibility takes a long period of time. So, I mean, working with Kent and the KCC and the ICB, actually we're looking at how do we work with their partners, with care providers and so on and so forth, so that they can start to understand the thresholds because there are occasions where a safeguarding concern is raised when it's not actually a safeguarding concern, it's actually a request for a Care Act assessment. So we are looking at use of AI that can help us distribute information into the right teams and so on and so forth. But it is a challenge, absolutely is a challenge. And when it's organisational concerns, so if it's a care home where we've got concerns about the care home specifically, obviously there'll be a number of residents in that home, so we're having to think about how do we safeguard all of those people in there. So it's a challenge, absolutely is a challenge, but we're looking at ways of how we can mitigate risk, how we can work more smartly so that we don't end up having to keep saying we need more staff and more staff, because obviously the budget is a real challenge for us. We talk about, is it a good thing or a bad thing, and the number of safeguarding concerns. Obviously for the team it's very demanding, but actually the fact that people know to raise a safeguarding concern is really positive, and we want to be making sure that we're doing the best for the residents in supporting them. With regard to the MISS team, so Medway Intensive Support Team, so we're in early days. It went live in June, and by the time we'd recruited, it was probably August-ish time that we had a complement of staff. But we did talk about this in a meeting earlier this week, and I can't remember what it was, but we talked about the numbers and the data, but we've got some absolutely brilliant real lived experience stories and the impacts that it's had on people's lives. So I'm quite happy that we can share some of that information. We can redact it and pass that round. It is working really closely with housing, with rough sleepers and so on. And actually, I spoke to the manager, the principal social worker of the MIST team yesterday. For somebody who's been rough sleeping for 3 years, MIST has been involved, and we've now removed them from the streets, and they are in accommodation. So yeah, really positive.
Chair, if I could just come back.
Sure.
I think in terms of the increase in staff to deal with safeguarding concerns, I think from a budget perspective, it would be good to know that bigger team is having an impact. Or equally, you're going to come back and say the team's not big enough to have an impact. There's a two sides to that same coin, isn't there? And I note the 7 million overspend in adult social care, for example, and I've got a question about that a bit later. But I look forward to seeing that information. In terms of cuckooing, I think the police are really key here, aren't they? And getting intelligence from the police. How does that bit of the system work to make sure that those adults the police come across are being correctly identified to Medway, and then we can take some action as well? Thank you, Chair.
Okay. Thank you. Sorry, so just to give you an idea of data, we had a number of cases that were over 12 months old from a safeguarding perspective. As of the 5th of January, we've got none over 12. So we are seeing that shift and that move, but I can actually give some data. So with the way that the MISS team works is what we call, is going back to old school, which is a team around the person. And I think of the common assessment framework when you have a team around the child. It's the team around the person. And actually, wherever we're working with somebody, it's a mix. So we've got police, KMMH, it's a real multidisciplinary team, and we ask people to come in as they go in. And so the relationship that we had with the police was good anyway, but actually that's really enhancing it, because it's sometimes just a call to say, look, we've come across something, can we have a chat with you, rather than immediately raising a referral of any sort. So it is having a positive impact on those relationships.
And I think perhaps before you come back, Andrew and Victoria, I think sharing some of the data, absolutely, Jackie, but sharing some of the case studies will be very revealing. And I do say to the board, and I think, Andrew, thank you for the commendation that you gave. When we came to the safeguarding executive, I think everyone there commended the work of the MISS team as being innovative. And this is not just a concept. This is people going into these places with their sleeves rolled up, sorting things out. That's what our staff are doing. So the fact that we've had an increase has enabled the ability to do that, rather than to kind of helicopter over it and try to get, somebody in from the voluntary sector who might be able to help. This is taking action quickly, and it has made a huge impact. And I think the last time we were here, Andrew, you asked, will safeguarding referrals ever go down? I think the answer to that is no, they won't. But what has gone down is the waiting list and our ability to deal with things quickly and prevent them from escalating into something worse. Andrew Raby, please.
There's a lot of Andrews here today. It is. Just two things, really. I think it's a really valid point you raised, and I'm really pleased to hear Jackie respond in the way she did about the Section 42s, because volume is challenging, and the first thing people look to do is to reduce the volume. But when people are reporting things when they have concerns about people, it's the right thing to do, and the right response is to actually embrace that report and encourage it. So I'm pleased to hear that. The other thing that we've spoken about, and I know Medway focused on, is preventative processes. You know, we are very aware that actually the reporting sometimes is because, and I talk to lots of organisations, charities and people who say, I refer because I'm not sure what to do. And what we're trying to actually say is there is an alternative. You can take responsibility. There are things you can do. And actually the report into the local authority shouldn't be the first step. So there is some work to do. Systemic change doesn't happen overnight. It has to happen over time. And that's a really important approach. Just the last little point, the issue with cuckooing is a really important one, and it is going to be very soon that it will be a criminal offence in relation to cuckooing. So the police are going to be able to play a much more important part of this, but I think it's important intelligence is part of that process. So what happens is we understand what is happening in people's premises, and it's not just young people. This affects people with learning disabilities as well. It affects lots of people in different groups and different organisations, or from different organisations, who want to live independently but are at risk because of their own different circumstances. So I'm really going to be on the front foot with this. When this comes in for royal assent, I think it's really important that we focus on this to ensure that we're given the right response, and the MIST team is the right response.
Yeah, and I think it's also worth adding the breadth of safeguarding these days is, you know, what comes to the council includes financial abuse, romance fraud, as well as all the things that we're used to, you know, such as self-neglect or physical and mental abuse from families. So the breadth increases every year. And whilst, you know, I really appreciate what the work the executive are doing in trying to divert people not away from the council, but someone who can help in a different way more quickly, you know, we have to take it seriously. And it was very clear to me when we did the stall in National Adult Safeguarding Week, people were raising those kinds of issues. You know, I had somebody raise an issue about a romance fraud affecting a colleague in a team of cleaners, and we have to take it seriously. That person had been so disadvantaged, they were going to a food bank because they'd been giving all their money away, and that, you know, can escalate if we don't arrest it. So I'm really pleased that cuckooing is going to be made a criminal offence. And, you know, the things that I've just mentioned are criminal offences, but tying people down, you know, there are whole companies working in other parts of the world to scam and defraud and inhibit the safeguarding of people here. And that's really sad, isn't it, that someone's got a career in order to make someone else's life worse, but it's the reality of what we're facing. And our teams have got to run to catch up, and at the moment I think they're doing a pretty good job. Any other questions, please? Tracy, thank you.
Thank you very much, and thank you for the report. Made really, really interesting reading. Just listening to the increase in the number of referrals, I mean, clearly they're far, far higher, and they've gone up quite rapidly in the last 5 years from what Jackie said. One of the things I wanted to ask in children's safeguarding, referrals, we have them broken down into who the referrers are, whether it's education, police, health and so on, and we can see the percentage that are converted to further action and which are not. I just wondered if that was something that happened with adults, if it was something that we could come back to particular sectors if we found that they weren't really understanding the thresholds and so on.
Working. Yeah, thank you. That's a good question. And we've, I'm pleased to say it's been on our strategic plan for some time now that we wanted a data dashboard to find exactly that out, because what we were saying is actually we've got this universal approach. We've done an awful lot to raise awareness of what adult safeguarding is, and so we've been sort of having that universal approach, but we noticed that the numbers were still sort of going up. So we've got that data dashboard now, and that's, I think we've had it for the last 2 quarters. It comes to our quality assurance working group, and I think it's fair to say, based on that, both Kent and Medway have looked at how things are reported in, so that actually it is being broken down now to sort of find those trends, to get those sort of a bit more granular information about the areas with the sort of different conversion rates, so that we're going to build upon that. We've also just done a referral audit, so we've got each agency to do a referral form audit, so that their safeguarding leads are having a look at what wider people in their organisation are sending through. So we're sort of trying to look at it in different ways, but that's been really helpful, I think, hasn't it, Jackie, in relation to where we're going to divert our efforts and things like that, because we've done some really strong work with the police and CCAM, because they didn't use the standard reporting forms and they had different processes. So we've got an agreed process with them, which has really improved the sort of volume, and so you know what's safeguarding, what's care and support. But this is now to work with, and I think it's found things that people weren't expecting as well. So it might be sort of different parts of the organisation. So it's been a really useful, but it's sort of, for us, it's in its infancy and we're building it up. But it's been invaluable already, I think. So thank you.
Thank you, Vicky. And just before you come in, Adam, I think that, you know, there's a real space in neighbourhood health for that kind of distilled information, so that the collaborative teams coming together will be able to pinpoint, perhaps more quickly than they otherwise could have done, where some of the issues affecting people's health is actually emanating from it, because there's no doubt about it, these safeguarding issues have a direct impact on the physical and mental well-being of the people that we're trying to keep safe. So being able, and actually a refreshed opportunity to remind people about the kind of intelligence background of safeguarding, that's an important question that you've asked, Tracy. And I think one of the sections of our partners who could do better on all of this are housing providers, actually, particularly with issues like cuckooing and, you know, other ways of helping us do preventative measures. And I think we'll perhaps have a talk with Bex Wilcox about bringing that together, and perhaps, you know, even bringing the housing providers, certainly in Medway, together to talk through some of these issues, to make sure that that intelligence is filtering through to them in a way that they can act quickly, and that they're playing their part fully, because just as things stand at the moment, I don't think they all are, actually. So that's important. Adam Price, please.
Thank you, Chair. Thank you, Teresa. First of all, I just wanted some clarification on, because it refers to the actual that strategy which this report is based on, and the actual that strategy, when you look at it, is 2022 to 2025, and then I read somewhere that it's been agreed that it will extend through to 2028. So if you could just fill us in on some of the background on that. And just to say that when I was looking in the links, and there's lots of links in this report, which is really good because it takes you through to the other supporting material that you need. I really enjoyed reading the easy read version of the actual strategy, because when you're dealing with safeguarding, you need to make sure that it's accessible as possible to both adults and the people caring for them as well, in order to be able to encourage more notifications. And then the other thing, whilst talking about case studies as well, of which there are quite a few, I was trying to find the one desperately now about which I enjoyed reading a couple of times in preparation for this meeting, which was about the older lady and her relationship with the social worker, and what the older lady said about the social worker fitting in with what you were saying earlier on about rolling up her sleeves. We're going to sort out the clutter. But also what the older lady said, that she really, that the social worker said that this is going to be an exciting journey for her. And there was a lot of positives that she was taking from that. And it really read to me like it was a partnership between the adults who was needing to be helped, and the care worker that was assigned to be able to work with her. So I thought that was really good. And then I also thought maybe where you're using some of these like anonymized case studies, that it might be like beneficial possibly to have some of those in easy read form as well, so that it can make it as it's a bit like having 60-page like reports and then having the executive like summary, but we're also talking about learning disability and other needs for these documents to be accessible. Thank you very much.
Yep, happy to. So, so just thank you for noting about the strategy. We took the decision to executive, and we had a strategic leads meeting in light of all the changes that are going on with organisations at the moment, and the changes that were happening. There was a proportionate decision made that actually our headings for our strategy are suitably broad to be able to encompass smaller, focused pieces of work like homelessness and things like that. So actually next week we've got a editorial panel, we're calling it, where we will go back and we will take off those actions that have already been completed and note those, but also have a really focused discussion with our strategic leads or their representatives to say what are those areas, those specific areas that it may be cuckooing, it may be exploitation, but are there some specific areas that we want to focus on in the next few years that we can sort of add? So there will be a sort of an addendum and an update, but it was felt that to take people's eyes off what they were doing at this time for this probably wasn't the best use of time with all the changes that are happening. And I'm really grateful for you talking about this sort of easy read version and things like that. Our communication engagement working group is working sort of heavily, and we're trying to borrow resources to do that, because all these things have got resource implications, unfortunately, but we've been sort of looking at our materials in different languages, and it's about how we share them and how we get them out, because so it's nice to hear that they're working, and we're trying to make use of videos and also working with other boards so we can share those costs. So we've got lots of videos on our website that's got video explainers. So, we're trying all the time to sort of make it as accessible as we possibly can. So, and like you say, it's those relationships that are so refreshing. I think as board members, I think we all get to see where things go wrong. We have a lot of safeguarding adult reviews. We're working through those. So that's why we really use this document and other documents to really champion. We have open sessions as well, don't we, Andy, where we get people with lived experience. We get people where things have gone right. We get, good initiatives that are going on so that we can hear that positive and where things are making a difference, because I think that's what makes our job a little bit easier and a little bit more manageable, I think. So, but thank you.
And then if I can just come back, Chair, just to say that it might be worth kind of on the title page of the actual strategy saying extended to 2028. So because obviously that original document is there and that can't be changed, but just so that people don't wonder why we're into 2026 and we haven't got a new one yet. Thank you.
I think that's done on the website, but I'm
the
pretty
website
sure
version
it's
it is.
done,
Yeah, but not in the papers for this.
No,
this-
of course. Thank you.
Apologies,
Thank you.
sorry.
Well, if it's
Yeah,
on the
not within
website-
it.
Anyone else, please? Right, well, thank you very much. We're being asked to note that report, and we've got a couple of recommendations there. I think it is important to put a meeting together with colleagues from housing. Absolutely, we'll get the data that Andrew Lawrence asked for circulated from Jackie, so to give that sort of closer look at what's happening with safeguarding, and some of those tidying up and accessibility issues, Adam, that you raised. I'm sure we can include those. So with that, is everyone happy to note the report? Thank you. So next, we're on to our adult social care strategy. And before Jackie comes in, I do want to commend the work that she's done to the board on this. We hadn't had a new adult social care strategy for a long time. And this one has been formulated taking great care to involve partners in the consultation about it. I was pleased to go to our regular monthly forum with care providers and hear what they had to say. We've worked through Carers First to hear what carers and those that they're caring for have had to say. We've talked to NHS friends and colleagues, and put in, as part of the strategy, a much greater level of regular engagement. And I think the engagement team have done very well, working alongside Sasha Kennard and others to make sure that this strategy is rooted in the reality of what we're doing and is relatable to all of the people that we work with in adult social care. And with that, I'll pass on to you, Jackie.
Lovely, thank you. So I won't go through this in detail. I just wanted to say, you know, Teresa's just mentioned there about the level of engagement, and sometimes when we do consultations, it's easy to do a consultation but then not react to it and actually keep the strategy the same. So I'm really proud actually that the feedback that we had, we made some changes to that, and some of it is very small. It was wording. People were saying it felt a bit patronising, and actually could we think about how we worded things differently? That came from our own teams as well. And others were more fundamental than that. So, you know, we've listened. We've ensured that it aligns with the joint local health and wellbeing strategy. We've made sure it supports the NHS 10-year plan and also the Kent and Medway integrated care strategy, so that we're not doing things in complete silo. Obviously, Councillor, once you mentioned the budget, you know, the strategy needs to do that flip and make sure that we're working more from a preventative point of view. How do we make sure people can be more independent? How do we make sure that people don't need a statutory service? I do have to say, though, with demographic growth going at the rate it is, it's going to be a challenge for us to bring numbers down. And it might be that we net things out, but will we ever get it lower is going to be an issue for us. In the paper, it talks about the costs. You can see, you know, our supported living costs have risen by 186%, and it gives other examples there as well. So it's a real focus of going from sort of really reactive to proactive, strengths-based approach. And we talked about the MIST team and the way they work. And what we've done is we've started to look at how do we roll that out across the division. So that is our way of working in Medway, starting with our transitions team. It's not going to be the same for everybody. There's going to be people that absolutely doesn't work for, but when it's appropriate, how do we do that? So it's got the 5 strategic commitments in there that are in the on pages 167 and 168. Oversight will be through my Adult Social Care Transformation and Improvement Programme, and also looking at the CQC Improvement Plan. We have to do quarterly returns to the Department of Health and Social Care, demonstrating where our improvements are. And there will also be oversight at the Oversight Board that Councillor Murray chairs. I am really proud of this. It is Medway's, the one that the previous strategy was drafted by somebody that is an interim prior to Leanne coming into post just as I was joining. So actually this is actually ours, and the teams are keen to progress and move this forward.
Introduction. Any questions or comments, please? Okay, Andrew, go ahead.
Thanks, Chair. So thanks for touching on the budget, Jackie. I'm just wondering because the budget's been through Cabinet, and I'm just wondering what the budget is. The budget being allocated enough to meet the demand that you know? Because the strategy's got to be underpinned by financial resilience and resources. That's my first question. Just on the assisted supported living costs, can you just give a very short narrative as to why those costs have gone up? I'm sure it's to do with accommodation, private providers, but that would be useful to know. I'm just wondering, in terms of the CQC improvement plan, what areas are being prioritised to improve that score from 59%, and what the plan is there. I mean, it's a great document. I love documents with big bold colours in because it really draws the eye. But what will success look like is all very, I'm going to get this wrong, qualitative. Where's the quantitative? Because I love data, but these statements like "I will enjoy equal citizenship with those who do not receive care" are lovely statements to make. But how do we actually measure? And how are you going to measure with someone who hasn't got necessarily the vocabulary to even understand what that statement might actually mean? It sounds very social worky to me, if you don't mind me saying, Jackie. Was there anything else? Oh yes, just obviously the increase of over 65s. I'm just wondering what we're doing in terms of infrastructure to meet those, severe physical needs. what does that look like? You might not have an absolute plan because obviously these things move on, but what that might look. And sorry, there was one more. The neighbourhood health care, the neighbourhood health plan that we attended. How does that affect your strategy? And are you going to have to do some pivot or keep the strategy moving so that it does dovetail into these, you know, more NHS strategic plans that come along on a very regular basis? Thank you.
Right, I'll try and remember them all. No, it's fine. So it's absolutely fine. Is the budget enough? I think anybody would always say that the budget is never enough wherever you are. So I mean, when we look at building the budget, we look at demographic growth and we do a prediction of what do we think it will be, and then how do we mitigate that so that where people don't need, you know, or shouldn't have care, then we sort of signpost them and move them on. I will not lie if I don't say it's going to be challenging. Absolutely will be challenging for us. And the increase in how we work in a preventative way and around reablement and so on and so forth. And I'm going to say working with our partners as well. We're working really closely with our colleagues at MFT, at MCH as well, about how do we make sure that when people are that we're either preventing people going into hospital, so that reablement work across Medway for all of us is really important, because if we can prevent people going into hospital, actually then it prevents people needing social care in that area. So we've just started a slightly different way of piloting reablement in our adult social care front door, so that if we see that works, it will help us bring down those costs. But it will be a challenge, you know. The supported living, why have the costs gone up? So we are definitely working with people who have more complex needs, and a number of the people that we are supporting will need 2-to-1 care or 3-to-1 care in the same ways for children's, because there's an element of they can't be left on their own because of their mental health, you know, not able to communicate, and historically, and I am talking a long time ago, that people would have been in an institution, which is absolutely not the right thing. So it's right for people to be living in the community, but it's about making sure that it's care that's not restrictive, but sometimes for their own safety and for the safety of the carers, that 2-to-1 and 3-to-1 care is needed. I would be honest and say that, and this is across the board from adult social care nationally, adult social care is picking up a lot more around health costs, and that's not from a ICB, not necessarily saying that they won't pay, but if something is ancillary, so somebody's receiving a package of care and part of that is something to do with health, then actually it sits within adult social care. So we're picking up more costs in that area as well. But we are working with our supported living providers and looking at, you know, how do we do things differently, and asking them to work with us and come up with different ways of doing things to try and bring some of those costs down. CQC improvement plan. So the priorities are very much, so when the CQC plan comes through, it scores in each area. So it sort of says to us, this is your lowest scoring area and so on and so forth. So we've looked at those areas and, you know, how do we make sure that we're improving in those? The plan is huge. So lots of work taking place. When we came up with that, Leanne was really clear about what does our short-term, medium-term and long-term look like. Some of the medium terms have slipped a bit, but it isn't a risk, and there's reasons and rationale behind that. But as I say, we have to report to the Department for Health and Social Care quarterly, and so far we've not had any feedback from what we're doing to say there's an issue, so that's positive. With regards to the qualitative and quantitative, so the wording in there is very much around the CQC. So they assess us on what they call I and we statements. So I am enjoying my care, I am finding that I'm living my best life, and then we are doing such and such. So we've based it around that. But a lot of that is picked up through the Adult Social Care Outcomes Framework statutory return. So it's actually questions that are asked when we just send out surveys, so that we can do both those qualitative and quantitative. And when we ask the questions of people, well, actually it's worded in a slightly different way that we map it. We also have what we're calling out, we've got our community engagement groups, the community information groups. So Councillor Murray mentioned earlier on about the engagement team. So we've actually started now, we've had one in Chatham, one in Gillingham, we've got one coming up in Strood, where we invite residents to come in and talk to us about adult social care, how is it working for you, you know, what could we be doing different? And then that helps build into the strategy and the CQC plan as well. And then with regard to infrastructure for over 65, so our commissioning team work really closely with planning, so that when they're looking at anything that's coming through from a planning perspective, if it's over a certain number of houses, we look at, is it accessible, can we get accessible housing, you know, making sure that it's accommodation that people with disabilities can move into. So they're having those conversations all the time. We do need more accessible housing. We often talk about people that maybe they're in maybe 3-bed houses rented, and it will get to a point actually they won't be able to afford that. So how do we manage? And what we want to do is enable people to stay in the community. And if we don't have that accessible housing, that becomes a problem. So that work is absolutely ongoing with Dave Harris and his team. And then with regard to the neighbourhood health plan, actually interestingly this morning I was looking at what we're doing for the next year or two, and one of the things that I've put in there that is fundamental that adult social care are core in that neighbourhood health team and not an add-on. I am part of the board, so sort of they have my voice in there. Not sure they're all keen on that, Mark, but they do anyway. But it is vital that we are part of neighbourhood health, and the strategy, because we've aligned it with the NHS 10-year plan, actually it does mean that we can dovetail it. And everybody's focusing on prevention. That's the key thing.
Just 2 very short comments. I think the reacting to feedback is really important. I really love personally the "you said we've done" approach, because I think too much consultation in the council, residents don't feel they're being listened to. School streets, Councillor Murray, for example. But that, you know, that's certainly on that. You know, we've heard you and we've done this. I think that's really important. I think in terms of accessible housing, it's good to hear that approach. My only concern is a lot of the new housing is more on the fringes, and I'm a little bit worried about how people might feel isolated away from the centre. How does, you know, someone who's elderly travel to our town centres, for example, to do their shopping and things like that? So much of the housing is going to be in areas where road infrastructure, bus infrastructure has got to be built. And it's how we manage that for the long. It's a 15-year problem. I appreciate that, Jackie, but something to bear in mind, I think. Thank you, Chair.
Yeah, okay, just coming back before anyone else does. On the financial management of the budget, Andrew, as you'll be well aware, we've introduced our FIP plan, and because of the investment that's gone into adult social care, the new heads of service are very embedded in budget management in a way that wasn't possible before because there just weren't enough people. So anything that we're doing to create cost avoidance is being embedded. So it's not just for this year that cost avoidance has happened. The things that have happened to ensure that those costs continue to be avoided in a sustainable way have gone into the team's own strategic plans. And actually, the teams are taking a much more strategic planning, sort of professional way of managing clients than they used to. So one of the things that I've been really pleased to see is when we have the whole of the division together, some of the newer people have been really enthusiastic about introducing a different way of looking at cases where everybody who needs to be involved is involved from the start and mandated to play a part. So that is making a difference. And on the over 65s, look, not everyone who's over 65 is going to need care. So keeping everybody well through our prevention strategy is absolutely critical. And in terms of housing, I'm very clear, although the statutory numbers of lifetime housing per development have now been reduced and left to local determination. As part of our new local plan, an inspector has been appointed. The work will start. We hope to be off the ground with the plan at the end of this year. It's moving a little bit more quickly than we hoped. I've been clear with the planning team, and Jackie has as well, that we still need to put those allocations in. And although, yes, there are greater developments planned outside of the towns, because of course there's more room outside of the towns than there are in towns. You know, a lot's being done now to improve the bus infrastructure. Bus journeys have gone up a lot. We've had some more money from the government to make buses easier to manage. We'll soon be introducing the real-time electronic signs right across Britain. That'll be managed by Kindy, which will be a huge difference because we'll have a grip on that. So it's not as if nothing is happening in order to prepare for this. And part of the new strategy, as I'm sure you've seen, is not just to talk to people who are recipients of adult social care now, but talk to everybody about what might be available in the future. And one of the reasons for that has motivated that, is that we have seen a much higher number of people whose self-funds are depleting more quickly. And of course, when people get to below a threshold, they come back into the council, and very often we have never had any interaction with the person who arranged their own care. And what they have frequently done is arrange care at a much higher level than we would have done to help them stay independent had they came to us in the first place. These are difficult conversations. One of the reasons adult social care hasn't got the public profile it deserves is because everybody hopes that it won't happen to them, and yet it's probably in the service in the council that affects most families somewhere at some time. So what the new strategies enable us to do is starting the conversation at a much earlier stage with everybody and making the whole thing a more accessible way of looking at kind of lifetime planning for all of us. So I'm hopeful about that, you know, not in a negative way, but in a positive way. What are the options? What do we need to do? How are we going to work together? And in a way, as ambassadors for health and well-being, the people around this table have got that job to do. You know, that's a discussion for colleagues at the hospital to have with people who might find themselves in difficult circumstances. And on your point about supported housing, we are seeing many more younger people, as Jackie has said, coming through from mental health, who are declared as clinically fit to come out of a long-term bed into the community. We want to support people as much as we can, but the complexity of their needs at a much younger age, and therefore for a much longer period of time, are a completely new element of what we can provide. The long-term future of this is to get our own supported housing, I'm afraid, so that we can be very, very careful about how we manage people and how we make sure they move on through life stages. So, you know, there's you'll have plenty to say, you and your colleagues, because very soon I think we'll be introducing having our own supported housing. We've got a workshop coming up for staff in adult social care, working with staff in housing to look at this issue, because what we can't have are people put into supported housing by a private provider whose business model holds them where they are for the whole of their foreseeable life. That isn't fair on anybody, particularly if it's someone younger who's transitioned from children's services into adult social care. So there's a lot of work to do, but the strategy is a really good stepping stone and a building block for making those things happen. With that.
Teresa, just to come back, I'm very supportive of the strategy. The strategy is a great start. In terms of assisted, the housing question, if we had more housing built for assisted living, it would free up family housing where people might feel trapped, and actually free up housing for other people. So I think it's a lot easier to build this type of housing than it is to convert some types of housing. So absolutely. I think on your point around young people coming through the care sector and other routes, I absolutely agree with you. The problem with it is the private sector are holding councils to ransom. And, you know, if there isn't a market in that provision, then of course the council's going to be held to ransom. So the council should look at ways of providing its own supported housing to mitigate costs. Just on the budget question, my concern here is, you know, another 10 million on EFS for this year, so makes 24 million in total. A big chunk of that sits in social care. And it's all I'm looking for was making sure social care is on a stronger footing rather than any political point around overspends, genuinely. Thank you.
Yeah, I hope the, you know, things I've said about the heads of service and the way they're managing things has given you that assurance. Anyone else, please, on the adult social care strategy? Tracy, thank you.
Thank you. I was really interested on the focus on prevention in this strategy. And one of the things I was wondering about are the families who have not been in touch with the council at all. Teresa mentioned those who have arranged their own care, but we've also got families, and I'm in this position myself, and we have an elderly parent still at home who, you know, you're managing, but how long for? Now, I feel in quite a privileged position because I'm quite clued up on what's available and what opportunities there are, technology and so on and so forth, but of course not all families are. So I just wondered, how do we identify these people? How do we make sure we get the right advice to families so that they can stay in their own homes for longer, so that they're able to be supported and that these families know where to go for advice and information and guidance?
So there's a mix of things. We're doing a guide to adult social care that's going to be going through our comms team and talking about everything that is available not just from a social care perspective, but what's out there. We are updating our website so that we can make people aware. We've been talking this morning about the how can we use the Joy app, which I hope nobody asked me too much detail about, but I've been told by the team it's very good, and that will also enable people to search for things. Some of it is very much about when people talk to us and to partners about what does adult social care mean. Because in the same way as somebody would be told to go to the emergency department, somebody is told to contact adult social care. And a lot of times people don't actually need adult social care, but there's a view that, well, I should get it because, you know, if everyone else does. So there's a real thing about changing culture and getting people to think differently and be more independent. And those community involvement groups. I don't know why I said information groups. Our community involvement groups, where they're out in Medway having those conversations, they aren't necessarily, as Teresa said, they're not necessarily people that are receiving the service. So it's about getting information out there about, you know, what is available, what can be done, and it doesn't mean that it needs to be an adult social care service. You know, we've been looking at other areas and the things that people do in Canterbury and up north and say, well, actually, we've got facilities in Medway. Why can't we replicate that so that it means less people come to us? I think the area where we probably struggle is where we say about people that we don't know. It tends to be where people maybe live in areas outside of Medway. Families move to Medway. They get to a point where they need some support and they're in a financial position that they make the decision to move to a care home in Medway. So we would never have had any dealings with them until their capital depletes. And we've had to have some very, very difficult conversations recently where people have been living in a care home for 2 or 3 years and then they're not Care Act eligible and we have to say, I'm really sorry, but we can't fund it. So we do need to get that out more. And I think having our engagement team is helping that. We've not had that before. That was part of the investment that was enabled us to bring that in so that we can get the message out more.
Anybody else on the adult social care strategy? And, you know, I'm sure partners around the table are very welcome to attend any of the engagement sessions and hear what people are saying. You know, that can be very instructive. Don't want to overwhelm people because then it will take time to build up as well. But the engagement team are doing a good job in letting people know about it. And I think, you know, when I go along to those kinds of sessions, they're normally very insightful and not, as people sometimes believe, people just turning up there to complain, but people genuinely, you know, having ideas and wanting to share their experiences. So I'm looking forward to that. Okay, thank you, everyone. We're being asked to note the report. We've got some helpful comments there from everybody. And I think what would be nice if we can come back to the board, perhaps in a year's time, to have a look at how we're doing, because I think that, you know, just as we hadn't had a strategy for a long time, the monitoring elements associated with having the strategy had fallen away a bit as well. So if we can make that happen, I think that would be very helpful. Okay. Now, would anybody like a quick break? We've got 2 more really important items to come, and we're doing okay for time. So if we take 5 minutes and see you back at the table. Right, so our next item, I'm very pleased to say, is the Marmot Place Partnership update. And it's been really timely that we're able to have sight of the draft report from the Institute of Health Equity. I've said many times now that being part of Marmot is not just an inherently good thing to do in itself, and obviously we are not at all starting from zero on trying to improve health inequalities. But what this has done, apart from refreshing our enthusiasm and giving us some fantastic access, actually, to the colleagues from the Institute of Health Equity, is to hold a mirror up to what we're doing and see if we're right about where we need to do most work. I think we are. And think about how we can focus, actually, the whole of the council's activities on reducing health inequality. And before Scott comes to introduce the paper, because we've got the opportunity today to change the recommendations, comment on them, anything that you think is missing from them before it goes fully into the public domain and will be launched. And before Scott gets going, I do want to thank you, Scott, for your personal enthusiasm and dedication to this activity. Scott's done loads of sessions to get the public engagement. We're the first Marmot Place to be putting together an asset map. And just earlier this week, we had our Marmot board, and what was really brilliant was to have Sir Michael there giving us personal commitment, as he's done every time we've met, which is amazing. And I was at an event with MVA a couple of weeks ago, and Scott said, oh, Sir Michael probably doesn't even know who I am. That is not true, actually. Sir Michael does know who Scott is, appreciates and praises him, not in a fulsome, fake way, in actually a very pragmatic, speaking truth to power way, as Sir Michael always does. So I do thank you for your work and enthusiasm. The Marmot team is a small team. The work involves all of us, but actually to have got this far in just about a year is a significant achievement. And so I hope everyone's had a chance to read the report, and I look forward, when Scott's finished speaking, to your comments.
Thank you very much. It is my job to do that, so that's fine. So just before, I'll just do a very brief introduction. I'm sure you've all heard about the Marmot Places initiative. Now, most of the questions is, what is it? What are we doing? Now, why is it any different? What's the impact it's going to be? So the report you have in front of you is the IHE's independent report to us. I say IHE's report, we've obviously, as a system, all Medway partners have contributed massively, whether it be EK360 and insight aspects, whether it be our own teams in terms of the asset work we've been doing. It is a shared support. I say this probably 9,000 times this week already. The Medway Marmot initiative partnership is not a Medway Council initiative. It is a Medway initiative. The report structure is meant to kind of act as a bit of a narrative and chronological fashion of what we've been doing since the launch event. Has been a little bit quiet on the outside if people are not looking in, but as you hopefully see in terms of some of the tools we've managed to produce and stuff, there's been a lot of work happening by lots of partners. Amazing buy-in from every partner. I've literally yet to find a partner say, no, this isn't the right thing we should do. But I've been part of public health team for 21 years. Initiative fatigue is real. Lots of nice slogans and lots of nice things. So the plan is not to make this a single public health team project or a Scott Elliott project or a Medway Council project, a genuine one that's owned. We know the NHS goes through its cycles of, reorganisation, really challenging with people. This has to carry on beyond that. We know there's pending government reorganisation in terms of local government. This has to be going beyond that. That is why it was purposeful we set a 10-year ambition. It's a 10-year ambition for Medway residents and Medway system, not an ambition that serves any other organisations throughout that. And we hope to see any new leaders across the system as they come, they go. Medway Voluntary Action will change chief executives a couple of times potentially in that time. How can we make sure that every partner carries on supporting this across all those sectors? It's difficult to say it's a good report because you look at some of the health challenging statistics. Mary mentioned the advisory group, but this is our real statistics. These are the things. Many of the comments, many of the content is similar to what you see in the health and wellbeing strategy and other things. You might say, well, what's new? What is absolutely new is the support of the Institute of Health Equity. What is absolutely new for me is nobody has said no to us going and talking to them about the positives of this. Just last week I was at all of Mid Kent College leadership team invited us to go and talk about health inequalities. That's never happened before. The Kent and Medway Housing Group, we're bringing up a log of every presentation we do in the partners, not to kind of pat ourselves on the back saying that's another good speech gone. We go back to those people in 3 months' time, 6 months' time, 9 months' time and say, remember the thing I talked about health inequalities? Well, what have you done about it? Not what's the 1.2 full-time equivalent staff done it in the public health team. And we're the Marmot team, not the Medway Council Marmot team. The report goes into some of the really fantastic insights, telling us what residents feel their experiences around that. That data bank is a massively rich thing. One of my biggest pet hates as a public servant is asking the same set of people the same set of questions and not actually doing something with the responses. So it's about building that database as we go on across it. We had really good response to our partners. We've got 89 little individual pieces of insight. So now we can layer that and see what are the common things that people keep telling us, but also are there communities who have not been heard at all? The asset map is going to be a growing thing. We know there's things on there that are happening already, but fundamentally the assets we have at the moment gives us the outcomes and data we've got at the moment. So if we want to do better, if we want to achieve our ambition of halving health inequalities over the next 10 years, we either need to spend that Medway pound better, or we need to create new opportunities, or we need to work more systematically, but basically do better as a system. So the final part is the recommendations. We will be Institute for Health Equity will be consulting all of our partners. The report you see at the moment is the sort of the unpolished report. It's it's the Word document version. We just finesse it as any errors, issues identified by the Advisory Group and Health and Wellbeing Board this week. We've tidied them up, be polished into a fully accessible document, created an executive summary without missing out some of the key bits, and we want to communicate the report to everybody, all 280,000 residents, all 10,000 potential partners, and say, what do you think? Not necessarily what do you think about the recommendations, but the second question of, and how can you help? How can we work more collaboratively? Then the consultation period closes by the end of April. That'll coincide with a NEAT summit event we're doing because it's one of the key themes. It's not the only important theme, but the intention is not to get NEAT, Marmot work focused on NEAT. It's about getting people involved in that agenda together, thinking about how they can work together, and then the Marmot team can exit stage left, and we can start thinking about the next priority that's been identified by residents, our assets. So yeah, any comments on the content, on the recommendations, be glad to hear.
Okay, any comments or questions, please? Andrew? Yep, go ahead.
I really don't want to lead off asking questions. It'd be nice if colleagues actually put themselves forward.
You love it, really.
Sorry?
You love it, really.
I really do, yeah. Scott, this is a really great read. However, from a personal point of view, I think what this is missing is the why there is health inequality. There's an awful lot about doing and trying to alleviate, but for me, if we don't understand the why, then all we're going to do is a cycle of trying to put right things that have gone wrong. So this is a very personal opinion. This is not a political opinion or, from anything. For me, I want to know why it is that, over a period of time, children who take free school meals are doing less well than other children. Why is that? We know it. The data tells us they are. They attend school less frequently than other children. They seem to suffer other deprivations. No one is seeming to deal with the why. And that's my big problem here. And the other thing I can't find anywhere in here is the accountability. You are accountable for your life. We are here, this thing will help wrap around and support you. But unless individuals at that level take responsibility for their own decisions, circumstances as well, we're never going to end this problem. And actually, Teresa, just about the safeguarding question, the ever-growing, this would just be ever-growing. These things tend to have a life of their own, and they get bigger and bigger. Now, I have found some really great examples of Marmot Place successes. So, for example, improved their index of multiple deprivation by 22 places. They used a job shop, for example. And there's been other impacts. There's a few other examples I found, which lead me to believe that this thing can work. But, from a public sector perspective or government, local government, we just seem to be constantly a bit like the boy in the dam. We're not really getting to the nub cause of why so many people find themselves in trouble. And the other thing is the use of the word equity. Now, my understanding of equity is sometimes you have to take resources from one group and apply it to another group to bring that group up. So, for example, if we're going to be investing heavily in new infrastructure in relatively poorer areas of Medway, because actually regeneration is a really important part of Marmot, but what does that mean for residents who live outside those areas and might want to access those facilities for their own healthcare? So how are we going to be dealing with things like that? I had a couple of other more sort of basic questions. I'm really interested in the NEAT summit. If there was any way I could get an invitation to that, I would very much like, because in the regeneration overview and scrutiny, I've been quite vocal on that, if you could send me. But one of the big issues identified is job density. Medway's got a very low job density. So what is our solution to that? We've identified it as an issue, just as one of very many issues identified in this report. But what are we going to do about that? So for me, we might decide to subsidise travel so young people can get jobs in Maidstone or London, for example. But I don't see any of those types of solutions yet. Maybe it's too early. And my final comment really is, how are we going to measure the impact of all of this work? Going back to the qualitative and quantitative in the social care strategy. I'd really like to understand how. Now, I know this is the long play, and it may well take 2 or 3 years before we see any real impact or moving the dial, but I'd like to understand that. Thank you for indulging me, Teresa. Thank you.
In terms of the why of the health inequalities, the 8 Marmot principles are written in the sort of positive language, so give every child a good start. So Michael, and we've got another employee of the University College London, so I'm sure Andrew will let me know, he's one of Sir Michael's peers. Correct me if I'm wrong, but the 8 Marmot principles are basically written based on evidence and data and science. This is not Sir Michael's opinion, issue of equity. This is based on science and based on statistics. And as Councillor Murray says, his role in life is to speak truth to power. He's speaking to the Italian Prime Minister or any of us at the Health and Wellbeing Board. So it's those reasons that are the why of the health inequalities. So if we then reverse the language like any good positive we need to do, we need to give every child a good start. Now, what does that mean? It is written in Fair Society, Healthy Lives. What does that kind of experience? Now, the 8 Marmot principles aren't meant to be distinct and individual. They do overlap. We give every child a good start by giving them a suitable housing and employment and skills and home. So they go through that. So when the first Fair Society, Healthy Lives was written, 2008, I believe, 2007, published, 10 years on, they did a follow-up report and they've seen there's 2 more indicators, 2 more reasons and drivers of health inequalities, and they added the 2. The first one was people experiencing racism and discrimination. So that is leading to health inequalities. Now, the reason for racism and discrimination is a whole societal, sociological kind of question as to kind of why do people hold those prejudices? What are the, are we set up as an environment to not allow someone to experience those things or enable them to experience those things? And the 8th one is really interesting for me personally around the link between the environment and the planet and health. We are seeing on a daily basis, internationally, globally, nationally, even locally, people in the lowest income brackets having the poorest health outcomes as a result of climate change and the difference change in the planet. So Michael is also, again, not afraid of talking to politicians, so some people might want to hide now. So he'll be citing, if you look at a graph, figure, I've lost the page now, the figure which shows the change of health and healthy life expectancy and life expectancy, and it'll point towards around about 2011 and the policy of austerity brought in by a coalition government. A disinvestment in public services is a fundamental driver of the reasons why. And again, he's got an avalanche of statistics showing how different countries have approached that, and the fact that not only have we had the slowing down of health inequalities, but we saw the first ever dip in recorded history in England outside of a wartime. And again, he'll show the sort of comparisons between France and other European states and other OECD countries of how that's happened, and the narrowing of and the widening of those health inequalities, as well as a dip in those aspects. And again, he'll point towards national policy recognition. So there are things that happen at a national level, and there are things around, food prices and cost of living and all those kind of aspects that are outside of our control. But the 8 Mark principles are not just meant to be written to say, this is a national, global, macro issues we can't solve. There are things that we can do locally. And as Councillor says, he's very positive and supportive of the way that we practice as a Medway resident. In terms of accountability of residents, 100%. What we haven't yet done, we've done a lot of thinking, we haven't yet resolved how we communicate this challenge and this agenda to residents. I always think about, the people that I see on a Saturday in a football changing rooms. If I go and talk about health inequalities, my mates will be a bit like, what does that mean? But if I talk to them about employment, this is why we're trying to use the building blocks of health as language, not wider terms of health. My mates understand if I haven't got good transport links, that's going to impact my health. They understand that if my dad's not living in a great home, they're going to have those things. So we try and talk about building blocks of health, but we haven't really kind of quite worked how to communicate to residents. It's massively important, but they even need to know we're a Medway Marmot place. We don't want to hide it from them, but really what they want is their lives to be improved. What we don't want to see is the other graph, where we have a 13-year life expectancy difference between one ward and another ward 4 miles away. That's not to make the top ward, come down. It's to bring the bottom up there. The other biggest thing you hear Sir Michael say, probably if you speak to him for more than 5 minutes, is the concept of universal portionism. And that's the thing he's mentioned around that distributing those funds. I always think health visiting is a great example of a really good universal portionism approach. Where my wife and I had 2 daughters. We saw the health visitor probably once or twice. I'm probably thinking they come to our house and said, white bloke, certain income bracket, health literate, ask the right questions, safe, secure, home, married, been for a couple of years, a homeowner, they're fine, they're going to ask the right questions and come back into me. Might have gone in the house next door, opposite, and seen a family that hasn't got one of those building blocks in life, doesn't have those transport links, doesn't have those things, and then their kind of risk level goes up. So they have a very, they're already conditioned to have a universal portion approach. Everyone gets the offer, but proportionally, the amount of time and investment and expertise that person gets will be different. But we do not see a universal portion approach right across all of our healthcare services, across our public services, across our voluntary services. We absolutely need to think about universal portion being a really key consideration for all the things our system does. If you take health screening, for example, if we just introduce another cancer screening project and put it in a car park which we think is accessible, it will be accessed by people who are probably in a certain income bracket, in a certain ward, with a certain ethnicity, with a certain thing. So we absolutely need to be thinking about a focused attention and key decisions being made on, we're going to do an investment in X, what are the net consequences? That's why one of our considerations, one of the recommendations is around an integrated impact assessment. So we can think about decisions that we make as a system, not just as a council, and if we can have a Medway integrated impact assessment, which some of the Marmot places have already implemented, are doing. As you mentioned, Coventry, great example. They have narrowed their health inequalities, which is no mean feat, because they also experience, same austerity. They also experience a global pandemic. They've also experienced the same grain prices affecting their food retailers. So it is possible, but it does take that concerted effort from the whole system. The integrated impact assessment comes from the North East, so again we have the pleasure of sitting on every 8 weeks going in and saying, what can you learn, what can we show? And we're definitely taking all those good bits around. That's another kind of a unique point around being part of that. Very welcome to the NEAT Summit, I'll make sure included. In terms of measuring impact, if you ask the same question to all Marmot places, and again, the Institute of Health Equity don't hide from this either, it's probably the hardest bit. It's a bit like our kind of child measurement and obesity issue that I've spoken about here. We can measure the kind of the high line level. We know what our health inequality statistics are like. We know what our healthy life expectancy will be. We know that family hubs, best start in life services, how many people access those programs from what communities. It's the bit in between. It's that kind of meso bit inside that. How do they interact? And what's the direct one that's linked to those things? That's probably the hardest bit that no one's truly nailed. But what we intend to do is do a 1-year on report every year. Because this isn't a single person's responsibility, this is all of our partners or residents ideally, we don't want to create a whole kind of delivery plan off the back of this. We'll end up just spending a lot of money, a lot of time just trying to work out and full in that. We want to, every year, come back and say, well, we've set the ambition of halving health inequalities in 10 years. Are we a tenth of the way closer to that next year? Because if we're not, we haven't done enough or at the right scale, we haven't done the right things, got the right thing. And at the same time go, these are the brilliant things. Neighbourhood health has been mentioned. If neighbourhood health take a universal portion approach and they're really making sure health inequalities is a key part of the consideration, we want to celebrate that. We want to thank them for it. We want to kind of go further, go faster, keep doing that. But if they haven't, we want to kind of say that's a missed opportunity. Can we think about that next time? Council can do the same things, child-friendly Medway, public health projects X, Y, and Z. Are we thinking about universal proportionalism, health inequalities in all the considerations we do? If not, can we do that next year? And that's where the ultimate governance for this sits with this Health and Wellbeing Board, and I'd hope that all of our partners here will be encouraging everyone to, carry on through the recommendations.
Thank you very much, Scott. I've got David and Leanne coming in, and then Andrew.
Okay, thank you. So I wanted to make 3 points. Scott's made 2.5 of them already. But yeah, so what I just want to do is illustrate something around the equity issue. So if we look at something like cardiovascular disease, and if we just think about it being it's a universal service, so anybody who's thinks they've got symptoms of cardiovascular disease can go to their GP, talk to their GP, get their symptoms registered, and then if they have a heart attack or whatever, they'll end up in hospital. When you look at the data, we look at the most deprived areas, they have the lowest, the GPs covering the deprived areas have the lowest rates of cardiovascular disease recorded in their patients. So you would think, okay, great, we haven't got much cardiovascular disease in these areas. But those areas have actually got the highest cardiovascular disease mortality rates. So a universal approach to things is not working. What we're ending up with is people in some areas who are not able to engage with the system, the health system, in the way that's giving them the same outcomes as other people. So we need to put in extra effort for those people to improve their ability to interact with the system and improve the ability of the system to deliver services for them, so that their outcomes then become the same as other people. So everybody should have the same type of outcome, but we need to put extra effort in certain areas or with certain groups.
Let me just challenge you back on that one point. Everyone has access to a GP, hopefully, if the ICB are doing their job. We've all got access to an ICB, to a GP. Why is it then that some people in, say, Luton, looking at these things, are not accessing their GPs? Is it lack of knowledge? Is it the GPs don't want to see them? Is it that there aren't enough GPs? And I've banged on about this continuous care coming from a GP. My big fear about neighbourhood health is that actually it'll become very, very fragmented. People won't know who to go to see for that specific. But in that just one example, see, the bit I struggle with is, in this country, people have access to a GP. Almost everyone is registered with the GP, except there are some people who aren't registered with the GP. So what is preventing that person getting that GP care?
So it's going to be a range of factors. Different people will recognize their own health and symptoms in different ways. So some people will be very sensitive to them and more aware of what important symptoms are for certain important conditions. If you just look at men and women, for example, women are much more likely to go to a GP if they've got symptoms. Exactly. So that is just one aspect of it. So there are different different groups have different health literacy. Then it could also depend on people's work. So if people are, say, on 0 hours contracts or have limited ability to go to GP appointments during work hours, then it's going to be more difficult for them to get an appointment. And there's going to be a number of other factors as well.
Thank you. Leanne.
Thanks. I do have a comment, but I mean, what you've raised for me is that age-old debate between nature and nurture, or nature and nurture the system, and where you end up positioning yourself will be, in my view, down to an individual's value base, their experience, or their political persuasion about, and wherever you sit on that continuum will give you the answer about what to do to stop it. So it might be that you say the individual is totally responsible, and you've given some examples, or it might be that you say the system is inadequate, and there'll be a whole range of opinions along that. And that's why Marmot, in my view, is good, because it comes from that universal perspective and it allows all peoples to be part of it. So that's just my opinion. But I mean, the use of GPs, I mean, I see some young people who, when I've said, come on, you need to register yourself with a GP, why? What's that got to do with me? You know, they've got youth on their side. They think they're going to live forever. You know, those sorts of things. My family doesn't, this is them, my family doesn't have a GP, why should I have one? You know, so it's all of those sorts of things coming into play. But my comment is, and I haven't read every single word of this, Scott, so it may be hidden in here somewhere, but violence against women and girls and the impact that has on health equity, I think, I know it alludes to it, but I think we're a bit light in terms of Medway. I think that in terms of health equity is more damaging than we realise. So I'd quite like something around that, maybe just a strengthening of what's in here, because I think if you look at referrals coming into children's social care, it doesn't take very many referrals before you come across domestic abuse, domestic violence, and the impact that has on the whole family, living in fear. And looking at Siobhan, because I think if I went up to ED and sat in the waiting room for an hour, I'd see some of the, you know, repercussions of that also. So I wonder if we could just have a bit of a focus on that as well. I was pleased to see tackling racism, discrimination, and it might come under that umbrella. But I think we need to be a bit more out in the open. Thanks, Chair.
Thank you. That's very important, actually, Leanne, because it can get hidden, and certainly it shows itself very much in housing these days. Practically, I think we were looking at some 40% of referrals for either different housing or needing to move are coming as a result of domestic violence. So that's a very important.
Thanks. Inevitably, of course, most of what I'm going to say possibly has already been covered, but as an aside, thanks, Scott, for the shout out to UCL. It was London's first university and was a mere 200 years old yesterday. When you consider the age of Oxford and Cambridge, it's a mere child, and London didn't have a university before then, which I think is quite staggering. But I'm a professor in a completely different area and not a statistician, so I wouldn't dream of arguing with Marmot's numbers. However, I wanted to address the, I think, suggestion that if we look at health inequality or health inequity, then there's a concern of redistributing funds to areas of need, which means inevitably taking funds from somewhere that's potentially more successful or working. And I don't think that's necessarily true, only if you look at it from a purely orthodox healthcare point of view. So if we accept that about 20% of your lifelong health and well-being is down to what we would consider healthcare services, the other 80% being what I call the wider determinants of health, but what Scott termed something much better, thank you. Then actually it may be about the more intelligent use of funds to address upstream those problems that are likely to cause disease and healthcare use later on. And if we do that, I mean, and that's obviously, that's what's in the 10-year plan. That's one of the 3 pillars of bringing prevention rather than treatment. And that's much cheaper overall. And we've known that. My gran knew that prevention was better than cure, right? We're just realizing that in medicine now. But, you know, roll on. Thank you.
Yes, thank you, Teresa. I would point to, because we've got chapter 3 there, and we've got the residents' input in terms of how they feel like about this, and it builds on what Andrew was saying, and also what Scott's building blocks, which is the 80% of things affecting people's health is outside of hospital. You know, once you get into the system, then you'll be accessing as far as possible the treatment that can be like available, but it is things like housing, employment, and actually, like from my perspective as a ward councillor on and off since the late 1980s, one of the biggest changes I've seen in Gillingham North Ward, which is one of the outliers or one of the more like deprived communities in terms of health like inequalities, like relates to the last time we had local government reorganisation, when education and social services was going to transfer from KCC to the new Medway Unitary Authority. Gillingham Borough Council was going to cease, Rochester upon Medway City Council was going to cease, and we were going to have the new Medway Unitary Authority. At that time, I was working for the then West Kent Health Authority, and my boss, who was senior in like commissioning within health, he got round the table with key people at KCC in the then CVS, which was then called the Council for Voluntary Services within Medway, and you know, obviously other like stakeholders, and they said that if we could make any impact on reducing health like inequalities, let's look at Gillingham North, as it was in this case, and the opportunity of the disused laundry at the Sun, which was formerly called the Sunlight Laundry, and let's build a community health centre there. So that wasn't taking anything away from anywhere else. Yeah, it was a brownfield thing. So what that then led to was that when the community was engaged in the old hall, you know, before any of the development took place, around what they wanted to see, they had post-its on the, you know, that were collected from individuals, as well as going up, you know, on the basis of their sort of like conversations. And the two biggest things was that they wanted was, one was access to a GP, which you've just referred to, because in those days, within the Gillingham North wards, you had to go up to the high street and beyond in order to get to a GP. Second one was access to a pharmacy. And again, you had to go up beyond the high street in order to access that. So fast forward, and we've just had our 20th anniversary of the Sunlight Development Trust charity, which operates within the building. Actually, the Sunlight Centre itself has been ongoing now for 30 years. So it was CVS that was running it before the Sunlight charity took over. But fast forward, we now have a GP practice there, which can be accessed for people going into that building, and we have a pharmacy. And the income from the rent from the GP practice and the rent or the lease costs given by the pharmacy goes in towards paying towards the costs of the charity staff. Now we have a number of charity staff there, but we also have a host of volunteers, and it's the volunteer bit which is the most important bit, because you're actually peer to peer, you're actually building up people's like resilience. So if I just read that bit from the chapter 3A, and it said that the highest number of responses from residents at the moment was, number 5, create and develop healthy and sustainable places and communities. From 81 comments from residents, there were a wide range of issues raised which were identified as contributing to residents feeling unsafe. So that's the crime one, but then there's the other one, which is even more than the 81. It was around, just going to bring it up to you. Yeah, number 6, strengthen the role and impact of ill health prevention. Okay, with 87 contributions, this principle had the highest response rate. It was felt that one's ability to engage in prevention of ill health was unequal and dependent on a range of factors, including life experience, language, confidence, level of knowledge, and existing health conditions. Residents also referred to healthcare constraining factors in accessing referral and assessment routes like for this. So what I'm saying is that there is a lot that can be done within the community, because we know that health is impacted more outside in the community than it is actually, you know, getting into the say like Medway Maritime Hospital, and some of those factors there around lack of confidence. We have a in the like Sunlight Centre, we have a cafe there with one member of staff who's in the kitchen, but supported by a team of volunteers, either like volunteers from the community or people who young people who are studying at Mint College doing catering and various courses like that. And they come and they do spells of volunteering. And in the early days, if you go up and you get a coffee or a cup of tea from them, then they're not engaging with you, they're looking down and they're not sure what to do. But within a few weeks, they're gaining that confidence, they're looking at you and they're smiling. And it's that investment in our volunteers, which then means that they've got that better access to a job in the high street. So that's the principle that I've been observing over the years. And I'm really pleased that we've still got the Sunlight Centre. And I would also quote from visiting politicians, I think it was including Gordon Brown, that once said, "I wish I could see a Sunlight Centre in every community," was what he was saying. So I just thought I would give those like reflections, and I'm really looking forward to the ongoing work from the Marmot principals, and long may it continue, and I look forward to the strides that we're making. Thank you.
Yeah, thank you, Adam, and everybody. And I think one of the standout things for Sir Michael himself was the resident insights.
Yeah.
He and the friends and colleagues from the Institute of Health Equity on our advisory board meeting made very specific mention of that, because actually there's quite a high number of resident insights. And, you know, in thinking about Andrew Lawrence's point about, well, why is it happening? Those insights show that people understand why it's happening and are displaying preparedness to work with us to change that. Any more comments on the report? So if we go, please, to the recommendations, which start on page. Yeah, so here I think.
You've got the big number.
Yeah, the chapter 6.
Page numbers. And then you've got the smaller numbers.
Is on page 265 of the agenda, page 51 of the report. You can see the recommendations there. They are deliberately high level and not granular, but I think, Scott, based on Leanne's contribution, there is room in the foster inclusive, culturally sensitive and accessible family support to add something about domestic abuse and violence against women and girls. I think that would fit there if you agree. And so specifically, any comments on the actual recommendations, Adam?
Yeah, and then the one bit that I forgot to mention when I was enthusing about what's been happening at the Sunlight Centre is that there's a number of groups which hire space there, and the one which has been one of the two that's been really consistent over the years is that the hall gets hired on a Tuesday morning every week by the One Stop Shop, which is about domestic abuse, and that's not just women being abused, but also men as well, although proportionately much more in the way of women. So by having the one-stop shop, people who are suffering from domestic abuse, and it is well known that we have a bigger prevalence of domestic abuse within Medway generally, and particularly in the inner city wards like Gillingham North, they have access to legal advice, they have access to housing advice, and all those basic things which they would need if you're trying to bravely get away from a broken home. And then just the final bit that I wanted to say on that is that I was a school governor for many years at Skinner Street School, which is now Oasis, and one of the most heartrending reports we had from the then head teacher was the practice that was happening whereby children were arriving at school in the morning with all their toys and possessions, and they were placed one end of the corridor within the school, because at the end of school they were then going to pick them up and go to another temporary accommodation. And you know what's changed during those years, but that's quite heartrending. The instability of living not in one place is bound to be a very detrimental impact on one's health, and the quality of temporary accommodation should be improved. Thank you.
comments from you, Scott, on this?
No, super helpful, thank you. So I've got a conversation with IHE colleagues tomorrow just to finalise those recommendations. We'll add those two aspects. It then goes off for 2 weeks to be designed, and then I appreciate board members' support to communicate the report and the recommendations. We'll have a kind of twofold bit, and these are recommendations. How can you help over the March and April period? So thank you.
Okay, so thank you, everybody. So are we happy to note the report in its present form and to add the things that we've heard about in the appropriate section? Okay, thank you. And once again, Scott, thank you very much for your work on this. Okay, I'm going to move now to our next item, the Integrated Care Strategy Update, and we're going to David Whiting for that, please.
Great, thank you. So this is an update on the Integrated Care Strategy. The Integrated Care Strategy is a joint strategy of Kent County Council, Medway Council, and the Integrated Care Board. It was developed in parallel with Medway's joint local health and wellbeing strategy, and there is good read across between the two strategies. So we have the joint local health and wellbeing strategy, which is the strategy of this board here, and then the Integrated Care Strategy, which is the strategy of the whole Kent and Medway system, and then the two sort of work together. The strategy has 6 shared outcomes. These are big, high-level outcomes. And then there's a monitoring framework behind it with a load of different indicators. In terms of the governance, the main governance route for the Integrated Care Strategy is currently the Integrated Care Partnership, which is a meeting sort of almost like a Kent and Medway-wide version of a health and wellbeing board. So it has representatives from KCC, Medway Council, the Integrated Care Board, voluntary sector, districts, representatives from some districts and some other organisations. And the meetings have been held roughly every 3 to 4 months. So over the last year or so, one or two of the outcomes have been brought forward to the Integrated Care Partnership for review, where we've looked at the indicators, looked at the inequalities in the indicators, and then had a focused discussion on one aspect of either one or two of those outcomes. So, for example, childhood obesity, I think, was the first one that we did. We've also looked at mental health and employment, and also more recently looked at frailty and linking in with adult social care. Since the creation of the strategy, there have been some important changes in the system. Integrated care boards need to reduce their operating costs by about 50% and become strategic commissioners. So this is changing the way that they're operating and means that some of the functions they've been carrying out will now be carried out or will be carried out in future by other organisations. And the 10-year plan talks about getting rid of the Integrated Care Partnership itself, so it will no longer be a statutory requirement. So locally as a system, we need to decide how we're going to go forward. And the really important part of the 10-year plan is neighbourhood health and how that is going to change the way that we work as a system to improve health outcomes. Neighbourhood health won't change, should still help us deliver the existing outcomes within the Integrated Care Strategy. The strategy is strategic, sort of it's in the name, and the indicators in the monitoring framework are also strategic. They're not operational indicators, so a lot of them only change once a year. And if you look at the other papers that you've had on the agenda today, all of those papers are talking about important work that will help to contribute to delivering some of the key outcomes within the Integrated Care Strategy. So I think I'll leave the introduction there and open it up to any questions or comments.
Just before I take other questions and comments, one of the things that we've been doing, as board members will know, but perhaps just for your benefit particularly, Siobhan, is taking elements of the joint health and wellbeing strategy and using this board to monitor how the indicators are going. And that's been a useful process. We'll continue. Integrated care strategy silent. One other thing to note is that the future of the integrated care partnership, of course, is changing. They are not required as a mandatory function under the new guidance, and we need to think about how we're going to make sure that we continue to capture the contributions and experiences of all of those partners as we go forward to neighbourhood health. So the next time we have an ICP, we need to nail that down, really. We've continued to have it at the moment, but we need to think about the future. Okay, Andrew?
Just a quick one. I mean, how is that transition from ICP into a new oversight, whatever it might be, going to actually happen? And is there a danger that things will get missed, in any of these sort of transitions? There's always something that falls between the gaps in the floorboards. It seems a little bit woolly at the moment. Is it because we just don't know, or is it the government haven't been very clear on what they expect? And I'm assuming Medway Council will be taking that sort of lead role in neighbourhood health plans as a leadership role?
Yes, absolutely.
So, but are we ready for that?
Yes.
Thank you.
Earlier, Andrew, the training that we've had, and there'll be another session, and then we'll bring to this board eventually a neighbourhood health plan. But what I'm keen to do, and there's absolute buy-in from ICB colleagues, is not to either duplicate or contradict the work that's been going on already in the programme board. So, and as Jackie mentioned earlier, she's very much part of that. So the council's feet are very firmly under the table as far as this is concerned. Adam, please.
Just in response to Councillor Lawrence's thing about what's going to happen when the integrated care boards go, I'm just looking at the 4.3.2 in the report, which refers to Fit for the Future 10-year health plan for England. This plan includes a stronger role for the Health and Wellbeing Board and a proposal to remove integrated care partnerships from legislation. And in so doing, over the 10 years, to make 3 big shifts: from hospital to community, more care will be available on people's doorsteps and in their homes. From analogue to digital, new technology will liberate staff from admin and allow people to manage their care as easily as they bank or shop online. And from sickness to that prevention that we were talking about earlier, will reach patients earlier and make the healthy choice the easy choice. So perhaps we ought to be doing some work on the future scope of the strengthened Health and Wellbeing Board.
I mean, Adam, that was the idea of doing the training. I think we're ready for that and glad to have a bit more time to look at it. And certainly as part of the consultation on neighbourhood health, there was a very strong sense of needing to work harder on the shared digital information about patients so that these neighbourhood teams can work effectively through the information that's being shared. Okay, anything... doesn't look like we've got any more comments from the board itself, David. Any?
We'll just come back on Councillor Lawrence's question about the ICB transition into its new form. So they're currently going through a consultation at the moment. Mark, you may need to just, you're probably more familiar with all the details at the moment. So you're currently in consultation at the moment on the restructure, is that correct? And how long does that have before it completes?
Yeah, I think we're into week 2 at the moment, so we've got a little way to go. So we are hoping to have it all finished by the beginning of April. But yeah, so we're in the middle of a restructure and a consultation.
Remember that that's the ICB, not the partnership. Yeah, not the partnership. Yeah. And I think actually, to be honest, what comes out at the other end of the ICB consultation will inform really how we manage the partnership, won't it? Because there'll be different people in place, and by that time we should know what we're going to do with the Health and Wellbeing Board. Okay, well, thank you everybody for that. If that's okay then, I'm going to note the approach that the Integrated Care Partnership has taken in monitoring and collaborating on delivery of the outcomes of the Integrated Care Strategy, and confirm that we will carry on with our monitoring of the Joint Health and Wellbeing Strategy here, so that we keep an eye on the things that we're doing. And that's a good example of the fact that, for Marmot, we're not starting from zero, but we can refresh and refocus our approach to some of the elements that are the greatest enemies of health equality. So I think that's something to look forward to, really. Okay, so I'm going to go now to the work programme, please, Terry. And people will have noticed that we haven't got Stephanie here today. Stephanie is doing something for the council on a legal process. I'm very grateful to Terry for stepping in today, as she herself, like me, has had a bit of a cough, and so I've been passing it around the council. But anyway, Terry, over to you.
Try not to pass too much around. I have nothing to add, but Stephanie assures me that David Whiting has an update in terms of the neighbourhood health plan at section 4. Thank you.
Thank you, yes. So the last time we talked to the board about the neighbourhood health plan, we were told that the deadline for producing it was by the end of March. So we needed to do some work before the next Health and Wellbeing Board. So we were going to have to produce it and submit it, and then bring a submitted report to the Health and Wellbeing Board. We've now heard, not quite formally, but reasonably formally, that the deadline's now been shifted until early May, which means what we can now do is produce the draft plan and then bring it to the Health and Wellbeing Board, the next Health and Wellbeing Board in April, to discuss before we submit it. So it means we will have a better process.
And if people just have a look on page 285, you can see the next board on the 16th of April. And we have actually got an update marked there, planned for the ICB structure changes. So just to give you a heads up for that we're hoping to hear from you. We've got a review of the themes that we explored in the last year, which I think is important, and they're detailed in this report too. The Neighbourhood Health Plan, the Community Safety Partnership Strategic Assessment and Community Safety Plan coming back to us. As I say, the ICB structures and the Corporate Parenting Board annual report. Okay, so that's our next lot. And with that, thank you very much, everybody, for your attendance today and for all the helpful comments.